Let me just start over. Okay. So mainly atelectasis is the closure or collapse of alveoli. So this is just where gas exchange occurs. So you have to remember that gas exchange happens in the alveoli. So if a patient comes in with atelectasis, um, they're just going to be having a lot of carbon dioxide accumulating within their body. So you always remember that if too much carbon dioxide is accumulating within the body, then that patient can go into an acidotic state. So can be acute or chronic. So most common is acute atelectasis, which occurs in the post-operative setting. So the whole thing with this is that these patients who have come out of surgery, they have shallow, monotonous breathing pattern. So that's why we always educate patients to turn, cough, and deep breathe, because it's very important to exercise those lung muscles to expand those muscles. Also want to educate them to use incentive spirometer because they can develop an infection like pneumonia. All right. Symptoms, insidious, increasing dyspnea, shortness of breath, cough, sputum production. Um, just an extra notes, the textbook said fever as well and chest pain. Um, Acute symptoms is that this patient's going to have tachycardia, trying because they're trying to compensate, tachypnea because they're trying to compensate, um, pleural pain as well, and central cyanosis. If large areas of the lungs are affected, um, this would be a late sign of hypoxia. So, like if cyanosis is actually occurring. Um, Chronic is similar to acute pulmonary infection may be present. So just think that the chronic nature of the alveolar collapse predispose the patient to infections. Um, all right. Assessment and diagnosis for atelectasis. So it is characterized by increased work of breathing and hypoxemia. Also going to hear decreased breath sounds. So you want to think that if you're listening with the stethoscope, there's going to be, you're not going to hear anything. You're going to hear diminished breath sounds that are going to be unilateral. There's going to be a collapse on one side. The other side will sound normal. There'll be, inflation, deflation. Um, all right. Chest X-ray may suggest a diagnosis of atelectasis before clinical symptoms appear. Chest X-ray also may reveal patchy infiltrates or consolidated areas. So if you've ever seen a picture of the X-ray, the dark part is basically just showing that there is a collapsed lung. Um, Pulse ox may demonstrate a low saturation of hemoglobin with oxygen less than 90%. All things like that. All right. The main thing would probably just be the nursing interventions. All right, so characterized by frequent turning, also just extra notes, coughing, early mobilization after surgery. Even if that patient cannot sit up in a chair, professor said gravity promotes circulation, and all that fluid is not sitting in the chest and will drain. So I always want that patient sitting up in a chair, if just going to a chair near them. Also, strategies to expand lungs and manage secretions. We use an incentive spirometer, which helps expand the lungs and enhances lung expansion, because you want to exercise those lung muscles after surgery. You just don't want that patient just sitting there. Voluntary deep breathing also is important. We always tell these patients to voluntary deep breathe at least every 2 hours because that enhances lung expansion as well. Secretion management. So remember, secretion management, that's coughing, suctioning for 10 to 15 seconds, or even nebulizer treatments. Also, CPT also helps with secretion management, so chest physiotherapy, where you have the hands cupped. And also, there's a CPT machine, if you think back to PEDS, where you can actually put a vest on someone, and it's vibrations that loosen up those secretions. Um, and then pressured meter dose inhaler. All right. Management of atelectasis, so improve ventilation and remove secretion. So all those things we talked about, CPT, suctioning, coughing, deep breathing, things like that. First line measure is going to be turning, early ambulation, long volume expansion maneuvers, and coughing. So all the same things that we've talked about, multidisciplinary interventions, so eye cough, additional treatments, PEEP, CPAP, bronchoscopy. Professor says she's not going to go like too deep with questions like with the PEEP and CPAP. I'm not going to go too deep into that. CPT. So remember what we talked about with the you know, CPT. You use your cup hand trying to loosen those secretions so that the patient can either cough it up or you can suction those secretions out. Endotracheal intubation and mechanical ventilation. So endotracheal intubation is required if both lungs collapse and the patient isn't getting any better, even after a thoracentesis. Remember, thoracentesis is to relieve that compression on that lung to get that air out. All right. I don't think this was on our blueprint. Let me just check. I don't think this isn't on our blueprint. I'm just gonna skip it. Pneumonia is. All right. To remember, pneumonia is inflammation of the lung parenchyma. So that all that means is that it's involved with gas exchange, and that just includes the pulmonary alveoli. So there's inflammation of those bronchioles alveoli. So it's a lower respiratory tract infection, which causes inflammation of those alveoli sacs, and it is caused by all these different various bacterias and microorganisms, myobacteria, fungi, viruses. And there's different types of classification. So community acquired would be, what's happening within a school, family, or shelter. Healthcare associated, another word for that, Professor pointed out, was nosocomial. So you get in the hospital, but you didn't come in with it, but you got it from the hospital and you went home with pneumonia. All right, hospital acquired. The textbook said that these develop 48 hours or more after hospitalization and does not appear during admission. So 48 hours after hospitalization. And then ventilator associated, if you're in the ICU, patients on a vent, and you, the nurse, are not doing proper hygiene, you're not changing that cuff every 12 hours, if you're not cleaning the sputum, all things like that, that patient can get pneumonia. All right, this is just like repeating it. All right, pneumonia risk factors. So occurs in patients with certain underlying disorders, heart failure, diabetes, alcoholism, COPD, and AIDS, also influenza. Cystic fibrosis, so if you think back to peds, these patients, they have thick mucus within their whole body, not just the respiratory system, but also the whole body. So if you have mucus, thick mucus, within, the lungs and within the bronchioles, and they just sit there and they get stagnant, that can cause an infection. Whenever something gets stagnant, infection, that's a way where bacteria can grow. So that's why cystic fibrosis is also a cause. Clinical manifestations of pneumonia, so varies depending on type, the organism, and presence of the underlying disease. All right, streptococcal, which is bacterial, sudden onset of chills, fever. With any infection, you'll see fever, headache, pleuritic chest pain. The patient says, when I breathe, it hurts. Tachypnea, respiratory distress. If it's viral, mycoplasma or legionella, bradycardia. Others be respiratory tract infection, headache, low-grade fever, pleuritic pain, myalgia, which means muscle pain, rash, and pharyngitis. This means like sore throat, inflammation of that pharynx, which is the throat. Um, Orthopnea, crackles, increased tactile fremitus, and thick sputum. Assessment and diagnosis of pneumonia, history, physical exam. In terms of physical exam, you're going to hear abnormal lung sounds when auscultating with a stethoscope. So you may hear coarse crackles if there's like a lot of sputum, maybe rhonchi, or bronchial breath sounds, things like that. Chest X-ray would be your definitive diagnosis. We can also do a blood culture. If your white blood cells are elevated, that indicates an infection. Sputum examination, if it's bacterial. Um, you know, the patient will like cough up their sputum, put it in a cup, put a label on it, send it to the lab. That's the sputum. What are the characteristics of the sputum? What color is it? Is it green? Is it yellow? That indicates infection. Bronchoscopy may be used for acute severe infection. Pneumonia prevention. So we know that there is a vaccination, which reduces the incidence of pneumonia, hospitalizations for cardiac conditions, and deaths in the older adult population. There are 2 types of pneumococcal vaccines. So that's recommended for adults 65 years of age or older, and 19 years or older are conditions that weaken the immune system. You don't get it your whole life, the vaccine, just more like the early years or later years, or you have an underlying problem. Other preventive measures are everything we discussed. So, patient after surgery, get out of bed, sit in the chair, turn, blow into the intensive spirometer, and that also helps prevent pneumonia. All right. Medical management of pneumonia, administration of the appropriate antibiotic as determined by the results of culture and sensitivity. Supportive treatments include fluids, oxygen for hypoxia, antipyretics, antitussives, decongestants, and antihistamines, all in one. It's like NyQuil or Dayquil. Antibiotics are not indicated for viral infections, but are used for secondary bacterial infections. So usually with viral infections, we just do symptom management. That COVID-19 considerations, SARS, asymptomatic to severe viral pneumonia, fatigue, myalgia, congestion, sore throat, diarrhea, anosmia, and ageusia. Most conservative outpatient treatments are usually just saying rest, hydrate, antipyretic, fever agents, things like that. Right. This is just repeating itself. Common complications, continuing symptoms after initiation of therapy, sepsis, and septic shock. This patient has a bacteria within their lungs, immunocompromised, maybe, things like that, respiratory failure, atelectasis, pleural effusion, delirium. Planning and goals for the patient with bacterial pneumonia, improved airway, increased activity, maintenance of proper fluid volume, maintenance of adequate nutrition. Right, so CPT, coughing, position changes. So it is really just like the same thing in such as spirometer, nutrition, hydration, rest, activities tolerated, patient education, self-care. Expected outcomes for the patient with bacterial pneumonia. You just want the infection to be gone, so the patient has improved airway patency, they rest and conserve energy, maintain adequate hydration, adequate dietary intake, verbalizes increased knowledge about management strategies, complies with management strategies, exhibits no complications. Aspiration, this was on our blueprint, yeah. Aspiration pneumonia. So aspiration can lead to pneumonia. So it's inhalation of foreign material into the lungs, which leads to inflammatory reaction, hypoventilation, and ventilation perfusion mismatch. So your whole goal is to expel or remove these objects from the lungs, these foreign material. Um, VQ mismatch, Professor went over a bit. All that is saying is that there's a lack of oxygen circulating within the blood. It is similar to pneumonia, serious complication are broncho or lumbar pneumonia, right? All right, so risk factor. Key patho is the volume and characteristic of aspirated contents. All right. So basically, what it's saying with like the serious complication of broncho and lumbar pneumonia, you're gonna see tachycardia, dyspnea, maybe even cyanosis because that's like in the lungs. This foreign, probably food, they probably choked. Hypertension, hypotension, maybe even death if it's really just like occluding the airway completely and no air is getting out of the lungs now. All right. Aspiration prevention. Prevention is the primary goal when caring for patients at risk for aspiration. So, during swallowing screenings, so usually the SLP will come in, they'll do a swallowing screening to see how that patient is swallowing. If they're not swallowing efficiently, then we're going to put the patient on precautions. All right. Um, Nursing interventions, you want to keep the head of the bed elevated and the endotracheal cuff elevated too if they're intubated. Avoid stimulation of the gag reflex when suctioning or other procedures, because then that's going to cause food to come up out of the stomach and then go possibly down to the lungs. Check for placement before tube feedings. Because it could be in the wrong place. It can get dislodged from the stomach and now from the esophagus and now be in the lungs. Also soft diet, small bites, no straws. TB, I don't, yeah, this isn't, oh wait, it is not. TB, contagious bacterial infection caused by Mycobacterium tuberculosis that affects mainly the lungs, but it can affect any other part of the body like kidneys, brain, spine, liver, things like that. It is spread via airborne transmission through droplets that move to other parts of the body, such as the kidneys, bones, things like that. So the whole thing with airborne transmission is that the bacteria, they're very small, so it can, suspend itself in air. If a person with active infection of TB talks, coughs, or sneezes, can be inhaled by others. Yeah. Just remember, like, risk factors if you're living in tight living quarters. Usually we don't see TB too much in the US, but it is seen in other countries. So if someone came in from a different country. Right. Assessment and diagnostic findings of tier 4 TB. You have a history and physical. So you ask the patient, where are you from? Where have you been? Like, where have you visited? Have you visited a different country where now you picked up TB? TB skin test, that's your PPD, your purified protein derivative. That's just another word, but that's your Montauk's test, in which you recently inject that tuberculin needle on the inner part of the forearm, and you do that, and then the patient comes back in 40 to 72 hours. A positive result doesn't mean that the patient has active; they can have a latent TB as well. The chest X-ray and sputum culture is the ones that confirm it if it is active. All right, TB blood test. That's more common now, so where we don't really have to do Montauk's anymore. We can usually just do a TB blood test, which is quantiferin TB Gold. Um, so sputum culture, that is called AFB. If you think back to MedSurg 1. So it's your acid fast bacilli smear. So that provides specimens through coughing it up or bronchoscopy to collect the sputum. The sputum basically dye it, and if it stains bright red, then the patient um, has having active TB. All right. Medical management of TB is treated for 6 to 12 months, so you need to educate the patients that they are going to be on these medications for a long time. CDC says treated for at least 6 months. Drug resistance is a primary concern because they are on antibiotics for a whole year, so they're tested for resistance. Initiate treatment with 4 or more medications, and you tell them to complete all the therapy. Initial treatment phase is 8 weeks. You treat with antibiotics. Prophylactic continuation phase is 4 to 7 months because you're trying to prevent it from flaring up, that TB. Because TB could be in you, but you're not having the effects. It's not active. So you just use continuous phase just so it doesn't become active TB. If patient does not finish antibiotics, TB will lay dormant in the body and flare up. Okay, so you want to, it's all about patient education. They need to take these medications. Nursing management of TB, promoting airway clearing. So that's all what we're thinking about, like coughing exercises, intensive spirometer, CPT, all things like that. Advocating adherence to the treatment regimen, promoting activity and nutrition. So you tell them to get out of the bed. Don't just lie down all day. Preventing transmission is also really important. Remember, this is you know, transferred from one person to another via air. So airborne precautions, negative pressure room, which you'll see like those practice NCLEX questions. Negative pressure room. So you want those doors closed at all times. You tell that patient to wear an N95 and strict hand hygiene. You want to isolate the patient, give a mask to people who they suspect with TB. You just educate them, cover your mouth, wash hands, isolate yourself at home for 2 to 3 weeks, wear an ME5, just all those same things. I think that's all with TB. Um, lung abscess. This is not on the blueprint, so I'm gonna skip it. Um, sarcoidosis is on it. Yeah, sarcoidosis. Sarcoidosis, it's a little difficult to understand at first, but the main thing with sarcoidosis is that it's an inflammatory disease where the immune system forms clumps of cells called granulomas, which can affect various organs, and most commonly the lungs. So basically, this occurs because the body's immune system mistakenly senses something is wrong and overreacts, forming granulomas. So we have like this, our body thinks that there's something wrong within our body, so it sends granulomas to help our body. Um, they're sensing something's wrong. So granulomas are like forming clumps within our lungs. And whenever something forms clumps, that's a problem. And any organ can be affected, but here we are focusing on the lungs. And it is chronic. So it's like there's no cure for this. Can happen between women 20, 40 years of age, so mainly young women, more common in African American women, usually occurs in smokers and Black women. Clinical picture depends on systems affected. So here we're focusing on respiratory, so dyspnea, cough, hemoptysis, congestion, anorexia, fatigue, and weight loss. So all things like that. So basically, you just have granulomas affecting the lungs, all right, and blocking them up. Assessment and diagnostic findings for sarcoidosis. You can do chest X-ray and CT scans. You can do a biopsy, and we know biopsies is our definitive diagnosis, which basically, they go in, they clip the parts, and it just diagnoses the patient. It's important to do this because we learned that it can mimic COPD. Sarcoidosis can do that, so that's why the biopsy is needed. Can also do pulmonary function test as well to see how the lungs are functioning. Also can do arterial blood gases, and like I said, you need a biopsy for definitive diagnosis. Management of sarcoidosis. So medical management, we said we also do oxygen, corticosteroids, which reduce inflammation. So for reducing inflammation, it makes it easier for you to breathe, because with inflammation around your lungs can be decreased. So people with sarcoidosis usually don't live too long. They may have spontaneous remission without treatment. Immune modulator, what these do, they help regulate the immune system to reduce inflammation. It's a medication, so it's oral, injections, IV, things like that. Nursing management, support all medical treatments, patient education for medication, and when to notify the provider. Or chronic illness management, contact foundation for sarcoidosis research, human resources, all things like that. Uh, but yeah, just think that it's just a blockage happening within the airway, and all the symptoms are pretty much the same whenever there's a blockage within the airway. All right, next up is pleural conditions. I want to see what she pointed out. Pleural pleurisy and pleural effusion. All right, I'm just gonna go to pleurisy. So pleurisy. So this is when the layers of the pleurae are inflamed or infected. Um, the main hallmark thing that's happening here is that the patient's having extreme pain of inhalation. So inflammation of both layers of the pleurae. Layers of pleurae are inflamed or infected, like we said. Key characteristic, which is your telltale sign, is pleuritic pain. Its relationship to respiratory movement. So when the patient is inhaling, there will be a friction rub, which is extremely painful. So the patient also has extreme pain when they're coughing or sneezing. That also causes a friction rub. Pleural friction rub can be heard with your stethoscope. Let's see. Diagnostic tests may include chest X-rays, sputum analysis, and a thoracentesis. A lot of times with purity, you can do a purulent drainage, purulent fluid to drain it. All right. The whole thing is to entreat the underlying cause, because you want to remember that these pleural conditions are side effects. They're not like an underlying like condition. They are side effects from an other bigger picture. And you want to provide an analgesia, because like we said, the telltale sign is pain. Teach to splint the rib cage when coughing. So pain relief is extremely important. All right. I believe pleural effusion is also on here. So I'll go into that. So pleural effusion is fluid collection in the pleural space, which is usually secondary to heart failure, tuberculosis, pneumonia, pulmonary infections, and really bad bronchitis with excess mucus, and cystic fibrosis. So remember, this is not a disease or anything. It's a symptom of an underlying, like something underlying like this. Um, Normally, the pleural space contains a small amount of fluid, like 5 to 15 milliliters of fluid, which acts like a lubricant so that we can inhale and exhale without pain. What's happening here is that we have too much fluid, and it can be clear fluid. It can also be bloody or like purulent, where there's an infection. All right. The main thing is you can have decreased or absent fret sounds, decreased emesis, um, flat sounds on percussion, may have tracheal deviation away from affected side, where the trachea just, turns to one side. Chest X-ray, chest CT, and thoracentesis, because we want to monitor the fluid analysis. So is this fluid clear, or is this fluid like green, where it's telling me that there may be empyema, things like that. Treat underlying cause. So rhedesis nurses must support the medial regimen and provide patient and family education. All right. All right. What else is on here? Um, We went over that. Alright. Okay, we went over everything in the blueprint for this. So I'm just gonna go to, with the time left, just gonna go over the other chapters. Over biliary first. All right, so just a overview. Gallbladder is what stores bile. Liver is what actually makes bile. Your pancreas is responsible for a lot. Mainly we focus on insulin and glucagon. So your beta cells are what produce insulin. Your alpha cells is what produces glucagon. So when the glucose is gone, we do get glucagon, and that's what stimulates our alpha cells to do so. When our glucose is way too high, our beta cells are going to release insulin, to lower it, put it inside the cells. So the picture of it, right? Cholelithiasis, which I believe is on the blueprint. Yes. All it is those are gallstones. Whenever you see like lith in it or anything like that, it just means like stones. So these are gallstones. Like they can be pigment stones, in which we're dealing with like a underlying jaundice, or it can be cholesterol stones. And there's different risk factors for developing gallstones. And this is just what it looks like. It usually just depends on how you're going to treat it. If there's like one gallstone, we can get out. But if there's like so many like this, like they're most likely are just going to remove the gallbladder. And a patient can survive without a gallbladder, because then the liver would just take over. All right. Clinical manifestations, none or minimal symptoms, acute or chronic. A lot of pain, because there's a blockage, there's a stone. Biliary colic, where that patient is gassy. Jaundice occurring as well. Changes in urine or stool color. Vitamin deficiency. And we do diagnostic tests for this. Medical management is ERCP. And basically, what they're doing, they're trying to get that gallstone out. Let's see if I have this. Oh, there you go. Yeah, so ERCP is basically when they just go in there with the scope and the camera, and they're just trying to get the stones out. It's only done if there's like not a lot, but if there's a lot, they can take out the gallbladder. Like I said, gallbladder is not a necessity organ because the liver can just take over. Dietary management is important. Not having a fatty diet, oily diet, things like that. Medications. These are the two medications. Professor said it can be like one or the other. Doesn't like matter too much. Because you're not going to give both. It basically just gets your body used to not having the gallbladder there. Liver takes over. There's also a lab chole that they can do, and that's basically when they go down there with the camera, they display the gallbladder and visualize the section of the organs for removal. We can also do non-surgical. The main one she pointed out was this one, where you basically just go there and use lasers to break up that stone, and so that it can be excreted via feces. All right, and these are the procedures. Lab chole. All right. Let me see if pancreatitis is on the blueprint. Yeah, pancreatitis is on there too. So pancreatitis is inflammation of the pancreas. It can be acute, where the pancreatic duct becomes obstructed. and enzymes basically just back up. If that duct gets obstructed, the enzymes back up, causing autodigestion and inflammation of the pancreas. So when anything is blocked, that can cause inflammation. Um, Patient can have fever, jaundice, confusion, ecchymosis in the flank, things like that. Chronic is progressive inflammatory disorder with destruction of the pancreas. Cells are replaced by fibrous tissue, things like that. All right, assessment of the patient undergoing surgery for gallbladder disease. You're just going to tell that patient, patient history, family history, knowledge and education, educate them on food, the dangers of fatty foods, balanced diet, you have to keep them on, things like that. Respiratory status and respiratory postoperative respiratory complications. So we learned about atelectasis, nutritional status as well. Monitor for potential bleeding, GI symptoms. Collaborative problems and potential complications to patient undergoing surgery. So bleeding is always a risk, GI symptoms, and this goes for like all surgeries in general. That's why we do the coughing, turning, and deep breathing instead of spirometry, things like that to prevent atelectasis. And then thrombophlebitis, prevent DVT, put the Vanadyne boots on. Planning and goals for the patient undergoing surgery for gallbladder disease. Goals may include relief of pain, adequate ventilation, intact skin, improved biliary drainage, optimal nutritional intake, absence of complications, understand self-care routines. All right, same things. Low Fowler position, NG or NPO, care of the biliary drainage system, analgesics, and then this is what we talked about a lot: turn, cough, and deep breathing. Ambulation is always important after surgery. Things like that. Collaborative problems with acute pancreatitis, fluid and electrolyte disturbances, necrosis of the pancreas, shock, MODS, and DIC, which Professor pointed out. When the blood just like clots briefly for a bit and then starts to bleed. All right. Tumors of the pancreas. And this was not on the blueprint. Just gonna go to the next one, which is hepatic disorders. So largest in the body, located in the upper right abdomen, a very vascular organ that receives blood from GI tract via the portal vein and from the hepatic artery. When it says vascular, just saying that it's an organ that has a lot of blood flowing in and out of it. Liver is just a really important organ. All right. Metabolic functions of the liver. The main ones we've pointed out and everything was ammonia conversion. So basically, we don't want ammonia, which is a toxin within our body. Our liver is supposed to convert it, and it's supposed to be excreted out of our body. If it doesn't leave our body, it can cause a lot of complications, and ammonia can actually go to your brain and cause encephalopathy. It can cause delirium and confusion. It's the main one. Bilirubin excretion. We know that our liver is supposed to excrete that conjugated bilirubin. So it's supposed to transform bilirubin from unconjugated to conjugated so that conjugated bilirubin can be excreted. So that's why it's important for, because if your liver is not working, it can't transform it. Bile formation, the liver is what makes bile. And what does bile do? Bile breaks down the food in your stomach. All things like that. Liver function studies, professors had to focus on these two mainly. AST and ALT. If they're elevated, there's something wrong with the liver. Clotting factors is also important. Serum ammonia. You never want the ammonia too high within the blood. Liver function studies, she just said to focus on these two. So we know that if ALT or AST or elevated can um, indicate a liver disorder. So we monitor for hepatitis. We're mainly going to focus on hepatitis C. Cirrhosis is permanent scarring of the liver. Um, the effects of treatments that may be toxic to the liver. Right, something for here. ALT and AST. If they're elevated, that's indicating that there's something up with the liver. Additional diagnostic studies, liver biopsy, ultrasound, CT, MRI, others. There's mainly those. Right. Assessment of the patient with alterations of the liver. So you do a health history, previous exposure to hepatotoxic substances or infectious agents. So, a lot of medications like acetaminophen, they're very hepatotoxic. So, has this patient been on heavy doses of acetaminophen? Are they traveling a lot where they're getting hepatitis? Because hepatitis is common in different places. Um, are heavy use of alcohol as well, heavy drug use, things like that. What is their lifestyle like? Are they doing drugs, things like that? Physical assessment, skin. So, like Professor said, ammonia can actually travel to your skin, and patients who are like on heroin use or meth, their skin can get very itchy. So you check the skin for like abrasions and cuts. Cognitive status as well. High ammonia can cause different delirium, things like that. Palpation, percussion as well. Um, Hepatic dysfunction can be acute or chronic. Cirrhosis of the liver, right? Liver failure associated with alcohol use, infection, fatty liver disease, so non-alcoholic fatty liver disease. It's not caused by alcohol, it's caused mainly by like the patient's diet. Basically, it's like if fat just backs up too much within the liver. Manifestations of hepatic dysfunction, jaundice, main one, right? Portal hypertension, and where that portal artery is like uh, very constricted, and now there's hypertension happening there. Ascites, in which that belly is big, that girth is really large, the waist circumference as well, and varices, and where there's bleeding within the esophagus. Hepatic encephalopathy, which we covered. You always want to think brain when you hear encephalopathy, and delirium, things like that. Nutritional deficiencies as well. So jaundice, yellow or greenish yellow sclera and skin caused by increased serum bilirubin levels. So the bilirubin levels exceeds 2 milligrams per deciliter. Hemolytic, hepatocellular, obstructive. Um, Hyperbilirubinemia can be hereditary. So if you think back to OB, um, some babies can have a pathologic bilirubin where they were born with it because of ABO incompatibility, or maybe that mom was Rh negative, baby was Rh positive, things like that. And then there's hepatocellular and obstructive jaundice. Professor did say she was not going to test us on this. Portal hypertension, obstructed blood flow through the liver results in increased pressure through the portal venous system, which results in ascites, so that increased abdominal girth, and esophageal varices, where there's like bleeding and there's ulcers in the throat. Ascites. Portal hypertension resulting in increased capillary pressure and obstruction of venous blood flow. Vasodilation of splanchnic circulation, so blood flow to the major abdominal organs. Changes in the ability to metabolize aldosterone, increasing fluid retention, decrease in systolic albumin, which is a protein, decrease in serum osmotic pressure, movement of albumin in the peritoneal cavity, just like that. Assessment of ascites, you want to record the abdominal girth and weight daily. Patient may have striae, distended veins, and an umbilical hernia. You want to think belly's big, so of course you can see these things. Assess for fluid in abdominal cavity by percussion, for shifting dullness, or by fluid wave. Monitor for potential fluid and electrolyte imbalances as well. Treatment of ascites. So we know that sodium follows water, so low sodium diet. Give diuretics to get rid of that big belly filter fluid, bed rest. Paracentesis, which is the main one she said she'll test us on, is which basically they go in and they're trying to drain all that fluid from the belly. Administration of salt poor albumin, because we need protein, but we don't want too much salt. So salt and water go hand in hand. Right. All right. Encephalopathy, you always want to think brain. So accumulation of ammonia and other toxic metabolites in the blood. Two major alterations underlies development, acute and chronic liver disease. Um, all right. Early signs are just mental changes where they're very delirious or motor disturbances, where they're possibly having seizures, and shaking, things like that. Assessment of stages of hepatic encephalopathy, changes in level of consciousness, potential seizures, fetal hepatitis. So you want to monitor fluid electrolyte and ammonia levels because you want to get those ammonia levels down. Um, Eliminate the cause. Lactulose, which is like a drink that they give them, and basically lactulose is, also helps to reduce the ammonia levels. IV glucose to minimize protein catabolism. Reduction of ammonia from GI tract. Discontinue sedatives, analgesic, and tranquilizers. Monitor treat complications and infections. Esophageal varices, that's the bleeding within the esophagus. We see these in patients who have, lung problems, but we can also see these in patients who have bulimia. Um, Manifestations include hematemesis, which means blood in your vomit, melena, which means dark tarry stools, so your stools are dark with blood in them, general deterioration, and shock. Whenever you lose too much blood, you can go into hypovolemic shock, hypotension, tachycardia. Patients with cirrhosis should undergo screening endoscopy every 2 to 3 years. Um, Treat for shock, administer oxygen, IV fluids and electrolytes. If you ever lose too much blood. Vasopressin, um, things like that. Nitroglycerin. All right. Okay. So you just want to maintain a safe environment, prevent injury, bleeding, infection, administer prescribed treatments, and monitor for potential complications. Always deep breathing and position changes, education and support, and family. All right. Hepatitis, she's only testing us on C. So C is mainly we see with drug users who are sharing needles. Most common bloodborne infection, a cause of 1/3 of cases of liver cancer, and the most common reason for liver transplant, right? Um, Management, antiviral medications, alcohol potentiates the disease, makes it worse. Medications that affect the liver should be avoided, like acetaminophen, which is very hepatotoxic. Prevention, public health programs to decrease needle sharing among drug users, screenings of blood supply, safety needles for healthcare workers. I can skip those. All right. It's gonna go to cirrhosis. Cirrhosis is scarring of the liver, and you never want scarring the liver. That's never good. Um, it's when it could be alcoholic. If someone's alcoholic, where they get cirrhosis, where scar tissue surrounds the portal areas, post necrotic biliary. All right, patho. Manifestations: liver enlargement, portal obstruction, ascites, infection, peritonitis, varices, GI varices, edema, all things like that. Mental deterioration. Um, you want to promote rest, improve nutrition, provide skincare, because they're going to have jaundice, reduce risk of injury, monitor and manage potential complications. Right? So promote rest, oxygen, rest, positioning, mild exercise, rest periods, nutritional status, so increase protein, things like that. I's and O's, frequent meals, high calorie diet, sodium restriction, because that risk of ascites. Skincare, gentle skincare, position changes, reduce scratching related to pruritus. So you think back to how ammonia can make your skin super itchy and reduce risk for injury, prevent falls and trauma related to risk of bleeding. All right. Uh, Complications, bleeding and hemorrhage, encephalopathy, think brain, delirium, fluid volume excess. I'm not going to go over fever. I'm sorry, cancer. All right. I don't think I have enough time to go over the next one. Uh, but if anyone has any questions, feel free to reach out.
All right, thank you.